Welcome everyone. Let's talk about diabetic ketoacidosis. DKA is an acute metabolic complication in patients with diabetes due to absolute or relative insulin deficiency. Usually it happens in type 1 diabetes, but could also happen in type 2 diabetic patients. What's the pathophysiology of DKA? Usually when there is insulin deficiency and the patient needs insulin replacement by subcutaneous insulin daily, when they don't take their insulin, or there is an infection or a trauma or a surgery which leads to increase in the release of counter-regulatory hormones called stress hormone, example glucagon, cortisol, adrenaline, growth hormone. So this will lead to enhanced hepatic gluconeogenesis and increase in the level of glucose also in the muscle cells. So what happened also, there is increase enhancement of the lipolysis, which leads to increase in the serum free fatty acid. So this is as a replacement of the glucose. What happens is that the free fatty acid metabolized to ketone, there will be increase in the ketone level. So that's why in diabetic patients, there is increase in the glucose level, then there is increase in the ketone level. This ketone level increases acidity. So this is what we call it DKA. So what happens when hyperglycemia happens? What happens when ketoacidosis? When there is hyperglycemia, it will lead to increase in the urination by osmotic diuresis, leading to polyuria. So the patient will have thirsty and taking a lot of fluid, lead to polygypsia. This will result in dehydration. Then when further increase in the dehydration, there will be hypotension and tachycardia. The patient have abdominal pain, nausea and vomiting. This might be due to impairment of the gastrointestinal motility. Respiratory, because of increase in the acid, body wants to wash out this acid by increasing CO2 excretion. So there will be increase in the respiratory rate, and there will be some metabolic acidosis. So there will be cosmal breathing. There will be smell of acetone on the breath. All this hyperglycemia and hypotension and dehydration and increase in the breathing lead to altered conscious level, lead to confusion and sometimes even focal neurological deficits and coma. So this is symptomatology of DKA. But how to diagnose a DKA? So to diagnose a DKA, you have to send some investigations. Most importantly, blood ketone level, glucose, and venous blood gas. So these are important to diagnose. If blood ketone level is not available, you can send for ketone in urine. Why we send for venous blood gas, not arterial blood gas? Because there is no much difference between the pH of the artery and vein. So it will not lead to any differences in the management. Then you send for some investigations like electrolyte, especially the potassium level, because potassium may be changed during the treatment. You send for the full blood count to see if there is any infection, to send for inflammatory markers, send for blood culture, urinalysis, chest x-ray. This is indicated only if the patient have signs and symptoms. ECG, you may send for ECG to see if there is any disturbance in the if there is any arrhythmia or electrolyte disturbance. So to diagnose the DKA, you have to find hyperglycemia or the patient having diabetes, acidosis by VBG, and ketone level. So if the patient have ketosis, acidosis, and hyperglycemia, this is diagnostic. Hyperglycemia when the glucose is more than 11 millimole per liter. To change it to milligram per deciliter, you have to multiply it by 18. Or the patient is non-diabetes. Acidosis, when you send for VBG, venous blood gas, venous pH less than 7.3 or bicarbonate less than 15. Ketosis, when the ketone in the urine more than 2 plus or in the blood more than 3 millimole per liter. Once you find this and you say this is a patient is diabetic, you have to start the treatment. What's the treatment? The treatment is starting with the ABCD. If the patient is having intact airway, this is good. If not, or the patient is unconscious, you may intubate the patient. You have to give high flow oxygen if the patient is having hypoxia. If the patient is unconscious or repeatedly vomiting, you have to put an NG tube to the patient. Coming to the circulation, if the patient is in shock state, you have to give 10 ml per kg bolus. The bolus should be given over 10 to 15 minutes as soon as possible. This is true for adult and for children. In adult, you can give 500 to 1000 ml per boluses. The type of the fluid is usually normal saline. For adult, usually if the patient, as we said, if the patient is hypotensive, you have to give boluses over 10 to 15 minutes and repeat it until the blood pressure become better. But then you have to start replacement fluid. The replacement fluid, you have to give 1 liter over 1 hour, then 1 liter over 2 hours, then 1 liter over 2 hours, over 4 hours, over 4 hours, over 6 hours. So this is in adult. Usually after the first hour, you have to start KCL as needed. The KCL per every 1 liter should be calculated. I will tell you about this later. If the blood glucose level is less than 14 millimole per liter or less than 250 milligram per deciliter, then you have to start glucose. You add glucose, not stop the normal saline. You add 10% glucose in a rate of 125 ml per hour alongside the 0.9 sodium chloride, normal saline. The insulin infusion must not be stopped because, why? Because for even if the patient have hypoglycemia, don't stop the insulin. Even if the patient have glucose level less than 250, don't stop the insulin because the insulin is required to stop the ketone production. How is that? The insulin is not needed to transfer the glucose into the cell, and the cell depends on the glucose as a source of energy instead of free fatty acid. The insulin is started in a rate of 0.1 unit per kg per hour. But if the glucose level is less than 250 milligram per deciliter, it's better to make the dose 0.5 unit per kg per hour. For example, in a patient with 70 kg, the patient should be started on 7 units per kg per hour, 7 units per hour. But if the glucose level is less than 250, you have to make it 3.5 or 3 units per hour. So you reduce the dose. An initial bolus dose of insulin is no longer recommended. Previously, the patients were given initial bolus. Coming to KCL, potassium. It's important to give potassium for patients with DKA, but once the potassium level return, if potassium more than 5.5, don't give. If between 3.5 to 5.5, give 40 millimole per liter per every liter. Every liter calculated, you have to add 40 millimole. If below 3.5, you give 60 to 80 millimole per liter. It's important to measure the urine output. Urine output should be more than 0.5 ml per kg per hour. It's important also to measure the venous blood gas in the first hour, then every 2 hours. Also put a Foley catheter to measure the urine output, NG tube if needed, low molecular weight heparin if the patient is having high risk of thromboembolism, and also giving antibiotic. Any infection, the antibiotic should be started with antibiotic. In pediatric patients, in children, and those people who are underweight, weight less than 10 kg, it is better to have another type of fluid calculation. This fluid calculation is somewhat complicated, but I will try to make it easy to you. So how to give fluid in these patients is, again, you give normal saline or Ringer's lactate, better to give normal saline. You have to give through this one. Requirement is equal to the deficit over 48 hours plus maintenance over 24 hours. How we calculate this? First of all, you have to give, if the patient is in shock state, give 10 ml per kg as a bolus. Even if the patient is not in shock, you have to give a 10 ml per kg slow bolus over 30 minutes. But this one, in shock state, you have to give over 10 to 15 minutes. So this is for shocked patient. If the patient, then after that, you have to send for venous blood gas. If the pH is less than 7.1, it means that this is a severe DKA. In a severe DKA, you have to assume that there is 10% deficit or 10% dehydration. If the pH between 7.1 to 7.3, it means that the patient is having mild or moderate DKA. In mild and moderate DKA, whatever the type, you have to regard as 5%, assume 5% deficit or dehydration. So the deficit will be calculated like that. The weight of the patient multiplied by 5 if mild to moderate, 10 if severe, then multiplied by 10 because to calculate the percent. And this is divided by 48 hours because you have to replace the deficit over 48 hours in order to prevent brain edema, cerebral edema. So this will be in mil per hour. This is one. Then the maintenance. How you calculate maintenance? With the weight of the patient divided into kgs. The first 10 kg multiplied by 100. Second 10 kg by 15. The other kg multiplied by 20. So this will be, the total will be the mil per 24 hour. There is another calculation in which in the first 10 kg multiplied by 4, the second 10 kg multiplied by 2, other kg multiplied by 1. This will be mil per hour, which is easier. And so I have to notify you that you have to calculate deficit plus maintenance in order to make it mil per hour. But for a patient with shock, if bolus given, that's given and you will not subtract it. But if the patient is not in shock, you have to subtract that bolus, okay? If the patient is not shock, you have to subtract the bolus in the 24 hour. We have to make an example to make it easier. There is a child. The child is 20 kg, okay, and has a pH of, the patient is in DKA, the pH is 7.15. It means that it is mild to moderate. So we assume 5% dehydration. How we calculate this patient? First, you have to say this patient is in shock or not. For example, this patient was not in shock. We given 200 ml bolus. 200 ml bolus over 30 minutes. Okay, so this patient, what is the deficit calculated? The weight of the patient is 20 multiplied by 5 dehydration multiplied by 10 because for the percent. So 20 by 5 by 10 equals to 20,000. Equals to 10,000. This 10,000 is divided by 48 equals to, sorry, this is equal to 1000. So 1000 divided by 48 equals to about 20 mil per kg. 20 mil per kg. So this is the deficit. So you write down here, you have calculated the deficit as 20 plus the maintenance is like that, 20 kg, first 10 kg multiplied by 4, and the second 10 kg multiplied by 2. The patient is 20 kg, so it equals to 40 plus 20 equals to 60 plus 60. So 20 plus 60 equals to 80 mil per hour. That's how you calculate the fluid for the patients. But you have to minus 400 per 24, minus 200 per 24 hour because the patient was not in shock state. So this 50 mil per hour should be started for this pediatric patient. What about insulin? If the patient is in severe DKA, so at that time you have to give 0.1 unit per kg per hour. For example, that patient, 20 kg, needs 2 units per hour. But if it is mild or moderate DKA, you have to give them 0.05 units per kg per hour. It means for this child, you have to give 1 unit per hour if the child is 20 kg. The potassium is the same as adult, but you have to calculate the bags. For example, if this child, we need 80 mil per hour, it means that during a 24 hour, we need about 2000. It means 2 liters. This child should receive 2 liters per the first day, per the first 24 hour. So this 2 liters, for every 1 liter, you have to give the calculated potassium, either 40 milli equivalent, or if the potassium level is less than 3, you have to give 60 milli equivalent per every liter. And I have to tell you that all these calculations better to be given through the infusion pump, because infusion pump can certify that this fluid and insulin goes in a correct dose. If not available, the infusion pump is not available, usually available in the ICU. If not available, you have to tell the patient's family to bring the flow meter. The flow meter is a metric that can give a good estimation for the flow of the fluid and the drugs. Coming to the complications, hypokalemia can happen in patients with DKA, usually due to the treatment, because when you give insulin, the potassium goes inside the cell, so there will be hypokalemia. If you give a lot of dose of high potassium, the patient might get hyperkalemia. Hypoglycemia also is a complication of insulin IV. Cerebral edema could happen, especially if there is fluid. There is a lot of fluid given, especially this is common in children. If cerebral edema happen, what will happen? The patients usually get in cerebral edema. Usually the child will get headache, then blurred vision, then they will vomit, then there will be other signs of increased intracranial pressure, then the patient become convulsion and coma. So if cerebral edema happens, you have to decrease the fluid by 50%, and of course elevate the head of the patient, and also you have to give mannitol to the patient. The mannitol dose is usually the 20%. You give 2.5 to 5 ml per kg. You give it over 30 to 60 minutes, and you have to consult the neurology. If the patient have lost consciousness, then you also call the RCU for possible intubation. If the patient is in shock or mannitol is not available, you can give hypertonic saline. The hypertonic saline that you give is usually 3%. You give again 2.5 or 5 ml per kg to the child. Pulmonary edema happens in patients with heart failure or patients with renal failure. Aspiration pneumonia could happen especially in patients who are in coma or due to decrease in the glucose scale. And thank you so much.